يلا صاروا دسوا.
Yes, feel free to start.
Okay. Hi, everyone. This is Dr. Kalin Jadam. First of all, allow me to thank Lundbeck for sponsoring this important webinar, and to thank IVPN, as always, for the highly professional hosting of such events. So today we will be navigating modern migraine management, the 360 holistic approach. So this is a talk mainly about eptinezumab as a treatment, as a prophylactic treatment for migraine, and a talk about recent updates in migraine diagnosis and management. So why are we still talking about migraine? Because migraine, first of all, as we all know now, is a highly prevalent disease. Prevalence is around 10%, meaning that within our participants or among our participants and attendees, so among every 10 attendees with us today, there might be one of them who has migraine and who lives with migraine and bears with migraine and tries to manage his migraine to live as much as he can a normal life and a productive life. So it's a highly prevalent disease. It affects mainly the young adults that are usually the productive population that interests us and interests medicine as a public health issue, because it's a highly disabling disease that affects highly productive people. And by disability, we mean a global burden. As we will discuss later on, it's a global burden affecting the productivity of patients, affecting the quality of life of patients, affecting their quality of life during the episodes of migraine and in the interictal phase between the episodes of migraine as well. And it affects them not only in their productivity, but on many levels in their daily life, as we will discuss later on. It affects almost 1.3 billion individuals globally, and around 7 to 8% of these people affected have chronic migraine. The rest will be having episodic migraine. Just a quick reminder, episodic migraine is all migraine that has less than 15 monthly headache days. With two subcategories of episodic migraine that we call the high-frequency episodic migraine and the low-frequency episodic migraine, with a cutoff of 10 monthly headache days. So other epidemiological data about migraine.
Okay. Are you sharing your slide? Because it's not shared on the screen.
No, it says you are screen sharing.
No, it doesn't show.
Now you are seeing me only, you are not seeing my slide?
Yes, now we are perfectly seeing your slide. Okay.
Okay. So it's the third most prevalent illness around the world. As we all know, it affects women much more than men, with a ratio of 3 times more likely to be affecting women than men. So another thing about migraine and disability and the global burden about migraine is that migraine is not just a headache like our co-workers or people in our lives would say. For example, a patient that says, I will skip today's event because I have a migraine, or today I cannot come to work, or I cannot be productive at work because of my migraine. Usually it is a bit stigmatized, and everyone would say, come on, it's just a headache, you can live with it. And in fact, it's much more than a headache. It's a headache that affects your productivity with two economic parameters that have been widely measured with migraine that we call presenteeism and absenteeism. Absenteeism being the days of our life that we lose due to migraine, where we cannot perform, where we cannot attend school or work or any event. And it's mainly absenteeism from work when it is an economic parameter. And presenteeism, it's when we manage to attend these events or to attend our work, but we cannot perform at our optimal level or at our usual performance level. Why? Because it's, as we said, it's much more than a headache. It is the headache phase itself that is usually moderate to severe, that is disabling, that prevents us from continuing what we are doing during the headache. With all the bothering accompanying symptoms, albeit photophobia, phonophobia, photophobia being disturbed from light, and phonophobia is when we are disturbed from sound and we have to confine ourselves to a dark, quiet room in order to alleviate the symptoms. But there is also the phases that come before the headache and after the headache also that are equally sometimes bothering. And usually in a minority of cases, around 25 to 30% of migraineurs may experience an aura that is 5 to 60 minutes before the headache. And this aura can have multiple symptoms. Usually they are visual symptoms, and usually they are positive visual symptoms consisting of visual scintillations, etc. But we can have other symptoms like tingling, numbness, speech disturbances, etc. And we have also the prodrome area that comes much more earlier than the actual migraine, and it can come up to days before the migraine. It affects the mood. We can have food cravings, photophobia, phonophobia, as we said before. Usually we can have fatigue, muscle stiffness. These are the most frequent symptoms that we may experience in prodrome. So the prodromal phase may be very bothering or equally bothering as a headache sometimes. And this has been an area of interest of novel acute therapies. And there has been investigations about novel acute therapies acting in the prodromal phase to prevent the subsequent headache and save the day, as we can say. And then there is the postdromal phase that can be also bothering, and that can consist of cognitive difficulties, fatigue, mood, depression, and muscle stiffness. So the burden of migraine is a composite value. It spans around many levels. The first level is the disability level. The second level is the level where our career, our productivity is affected. And here we speak about presenteeism and absenteeism. Other levels concerning the migraine burden are the interictal burden, the medication overuse, headache, and we will assess each aspect of migraine burden subsequently. The Cameo study assessed more than 13,000 people with migraine in the USA and found up to 1/3 of patients who said that migraine affected their career, and this is a huge proportion. And a quarter, to up to 25% of patients were worried about losing their job because of migraine, what we said, missing working days, absenteeism, or performing poorly due to presenteeism. The AMP study assessed, on the other hand, 18,000 people with migraine in the USA, and of these participants, more than half of them reported severe impairment and requiring bed rest, and 25% of them missed more than 1 day of work or school in the 3 months before the study. Burden can also affect and impact family planning, because, as we all know, migraine can worsen during pregnancy due to because of the fact that is hormonally effective and hormonally sensitive. So up to 20% of women avoided pregnancy because of migraine, and of those who avoided pregnancy, they had fewer children, were younger, and were more likely to have chronic migraine. So these are women who really suffered from living with chronic migraine, and this affected their life decisions, mainly family planning. In the Cameo study, more than half of respondents with chronic migraine said they would get along better or much better with their children if they did not have headaches. And this statement sinks in with me as a mother and as a migraineuse, because this is what I used to say before having proper treatment for my migraine. So I used to skip a lot of playtime with my daughter because of my headaches and my migraine. And this really, I really identify with such a statement. This is a reality. This is not overdoing things or exaggerating things. Parents miss a lot of playtime with their children, of family events, miss a lot of enjoying their time with their family or with their significant others due to the burden of their migraine. Living with migraine can also, as we said, impact the family planning, and sometimes it can impact the planning of life events or even outings. So sometimes people may postpone some life events due to anticipation. They may be afraid of the next headache, when it will come, etc. And it can also affect their marital life. 17% of patients reported difficulties in their love life. 1% reported marital separation or divorce. Also, 1% reported having fewer or no children due to the not due, but where the migraine burden acted significantly in these measures. So on the other level of the burden of migraine comes the comorbidities and the disability. Up to 2/3 of migraineurs experience moderate to severe disability according to the MIDAS score. 37% had some level of anxiety, and 35% had some level of depressive feeling. And this is not only for patients who have very severe migraine or chronic migraine or more than 20 to 25 monthly headache days. This starts for migraine as little as 4 monthly headache days. So even people who have the least or less monthly headache days, this does not mean that they have no disability. From there on, the higher migraine frequency is associated with even higher anxiety and depression symptoms. So the functional and emotional impact, as well as the comorbidities in patients with high frequency migraine, reach a disability almost equal as in those with chronic migraine. As we can see here, the mild to moderate disability was about 19% in high frequency episodic migraine and 18.6% in chronic migraine. The same goes for depression, 36% in high frequency episodic migraine and 38% in chronic migraine. Another level to discuss the burden of migraine. The patient burden increases, as we said, with migraine frequency. So as long as there is increase in monthly headache days, there is increase in the psychiatric comorbidities like anxiety and depression, but there is also increase in the disability according to the MIDAS score, or Migraine Disability Assessment Scale. The higher the scale, the higher the disability, and we observed higher MIDAS score with higher migraine frequency, with high frequency episodic migraine, and more so with the chronic migraine. All this leads us to a new mindset where we are eager to break the spectrum of migraine, because as we all know now, we are not speaking of very clear-cut episodic migraine, chronic migraine, low frequency, high frequency. Nowadays, we are more speaking about a spectrum in migraine where we can move around from a low frequency to high frequency episodic migraine, and even to chronic migraine if there is poor treatment or poor access to treatment, or poor access to effective preventive treatment, or we can even reverse the story from chronic to episodic migraine. Why we need this urgent need to reverse chronic migraine to episodic, or high frequency episodic to low frequency episodic? Because exactly we would be first of all improving the quality of life of patients, but also we would be decreasing the global burden of migraine, be it on the productivity, on the psychiatric comorbidities, or on the disability. What about the interictal burden of migraine? Interictal symptoms, as we said earlier, add to the burden of migraine by impacting the patients on headache-free days or less headache days, because 26% of patients reported not being entirely free of migraine symptoms interictally. Some patients would have pain on scalp, sensitivity on scalp. They would have low intensity headache in their background all the day. They would have some neck muscle stiffness, etc. So up to 26% of patients weren't really headache free on their interictal days. They were just doing better than their worst days. 11% reported anxiety about the next episode, and this is anticipation. And this is where they may miss events or miss important dates in their lives because they are afraid that migraine might kick in during these events. 14% reported lifestyle compromise and avoiding behavior. The mean time spent in the interictal state was about 300 days per year. That means that during 2/3 of the year or 3/4 of the year, we are anxious about when we will have the next migraine, or we are planning our life around our migraine days. And then the last aspect of migraine burden is related, as we all know, to medication overuse. And medication overuse headache is like a vicious circle. It's hell for both the physician and the patient, because for the patient, he won't know where to stand, whether he should stop his acute medications and bear with the withdrawal symptoms, or continue seeking poorly effective acute treatments and sustaining the medication overuse headache. But the main actor in medication overuse headache, where we should act to break this vicious cycle, is the poor control of migraine. Usually when migraine is poorly controlled in acute treatment, this is where we seek a second dose. This is where we seek a repeat dose during the day. This is where the migraine or medication overuse headache is entertained. The second component where we should act is proper prophylactic treatment, because the better we control migraine, the less there is need for acute treatment. So first, we should decrease the need for acute treatment, and second, we should have an appropriate and efficient and fast-acting acute treatment. So poor control of migraine is usually related to interictal anxiety and the potential for medication overuse. 15% of people with migraine felt they were rarely or never in control. And this was associated with a fourfold higher rate of interictal anxiety. Feelings of control are largely dependent on the effectiveness of acute therapy, and inadequate efficacy of acute treatment may lead to more frequent dosing and overuse. But now this is changing, in fact, because now we are lucky to have the novel acute treatments in migraine that are the GEPAN, that are providing excellent results in terms of tolerability, in terms of safety, and in terms of effectiveness. So we are being able to break the cycle from one arm by providing novel acute treatments for migraine that are at the same time tolerable, safe, and efficient. And on the other hand, by providing effective prophylactic treatment that decrease the MMD in frequency and intensity, and thereby decreasing the need for acute treatments and the need to seek acute therapy, and decreasing the medication overuse headache and breaking this vicious cycle. So there is a potential for either breaking the vicious cycle of medication overuse, or even reversing the spectrum of migraine from chronic migraine to highly frequent episodic migraine to even low frequency episodic migraine, and reverse the natural history of migraine that was prevailing up till now, where people were seeking poorly efficient acute treatments that may have a lot of side effects like triptans. We're seeking repurposed preventive therapies that may have poor effectiveness or modest effectiveness, and at the cost of side effects, and year by year developing a higher frequency episodic migraine, and then developing a chronic migraine. Preventive treatment can play a role in reducing the impact of migraine and medication overuse headache, and this is the main take-home message. We can reverse the we can reverse the history of the migraine spectrum, and we can break the cycle of medication overuse headache. But the key factor here is early intervention, because the earlier we act, the higher the chances to achieve this target more quickly and more efficiently. When a patient comes already with a chronic migraine, with a medication overuse headache adding to the picture is already difficult to change. So early intervention and rapid-acting preventive treatment of migraine aims to reduce the frequency and/or severity of attacks, reducing acute medication use, improving responsiveness, and alleviating overall disability, and improving quality of life, and therefore preventing a disease progression and escalation in use of acute medication. So this was the old picture concerning migraine. or at least on what concerns us. In the UAE, we are lucky to be speaking of a paradigm shift, totally contrary to the current slide, where we are having access to appropriate acute treatments, where we are having access to appropriate, effective preventive and prophylactic treatments, and where we are being able to successfully break the vicious cycle of medication overuse headache and reverse the spectrum of migraine from chronic to high frequency to low frequency episodic migraine. But overall and globally, this is still a highly unmet need, and there are still highly unmet needs in terms of access to proper acute medication. We are still using triptans very widely globally. And as we all know, there is poor patient persistence due to side effects, due to poor tolerability, and there is a risk of overuse of over-the-counter acute treatments or triptans. There is still an unmet need in the preventive treatments. So usually we don't reach the anti-CGRP medication except after trying between 2 to 5 oral preventives. And this is really very limiting for physicians and patients, because now the new guidelines of the American Headache Society, the new consent, states that anti-CGRP medication can be given as a first-line treatment, and we can skip all this agony for patients going through repurposed drugs with poor tolerability, with poor effectiveness or modest effectiveness, with all the side effects that can come along, etc., and provide a proper preventive treatment for migraine. Up till now, preventive treatment is underutilized in eligible patients. This is the Overcome study that assessed 21,000 individuals with migraine in the States. So the eligibility criteria were more than between 3 and 8. So this is the low frequency episodic migraine with severe disability despite appropriate use of acute treatments, intolerance to acute therapy, contraindications for acute therapy, management of medication overuse, headache, and patient preference. So this is the comparison between patients in light blue who are eligible for a preventive medication, and in gray, the patients who are actually using the preventive medication. And we can notice the huge gap between patients who are eligible and patients who manage to have access to these preventive medication. As a take-home message, migraine is a complex neurological disorder that places a large burden on patients. Patient burden is high even when we have when we are at 4 monthly headache days, but increases with increasing headache frequency. Effective preventive treatment are often introduced late in the treatment process and may be underutilized, but can reduce migraine attack and headache day frequency, disability, interictal burden, and improve quality of life. So 3 take-home messages: act early, provide access to highly efficient acute treatments, the novel acute treatments, and provide access to the highly efficient anti-CGRP preventive medications. So now we will leave the questions for the panel discussion at the end of our session, and I will introduce the next speaker. Our next speaker is Dr. Suzanne.
Yes, I will be, but can you please just stop screen sharing? Yeah, okay.
Okay, that's it. If you want to share your screen.
Sure.
So Dr. Suzanne Nouri is a senior consultant neurologist at University Hospital of Sharjah and assistant professor in the Medical College of University of Sharjah. She obtained her MD in the University of Khartoum and is a fellow of Royal College of Physicians of Edinburgh. She's a member of the AAN and she holds conjoint academic responsibilities in the University of Sharjah. She's a member of many professional bodies locally, regionally, and internationally, and as well as a member of many quality committees and task forces. She has been actively involved in different meetings and forums, as well as in the media, and had coordinated regular campaigns for raising awareness for MS in her community. She's also implicated with the headache as area of interest, and she will be talking to us about the, excuse me,
The unlocking powerful
the
relief
unlocking
about
powerful
diabetes.
relief of actinizumab episodic and chronic migraine.
Right. Thank you very much, Dr. Khalil, for the introduction. Thank you, IVPN, and thank you, Donbek, for the invitation. Thank you, Dr. Khalil, for the introduction, as well as for setting the stage to talk about the powerful medication that can transform lives for many patients with migraine. So this is, just let me move the slides. So migraine is a highly prevalent, as you already have stated that, and unfortunately, it remains underdiagnosed and undertreated, and that creating a significant paradox in the healthcare. So almost half of our sufferers do not get an accurate diagnosis of migraine, and only very few, around only 12% of patients who got the diagnosis gets a proper preventive treatment. And this shows the enormous alarming gap between the diagnosis and treatment. And this gap not only affects the patient's quality of life, which already have stated very elaborated on that very well, but also contributes to a high rate of migraine-related disability. And we already talked about the disability, so I don't think I need to go through that again, but I just need to mention that WHO has already considered a day lived with severe migraine as disabling as a day lived with dementia, quadriplegia, or acute psychosis, and more disabling than blindness, paraplegia, angina, or rheumatoid arthritis. So this reflects the magnitude of the disability of migraine. So, and this also a call for getting a successful and powerful medications that can prevent the suffering of these patients. So when selecting a preventive treatment for migraine patients, we have to consider many factors, and some of these factors are related to the patient themselves, the frequency and the severity of their migraine, the potential side effects, their previous experience about the other medications, if the patient is having any comorbidities, what was about tolerability of the other medications. Patient's preference is quite important because we have to consider this because otherwise patient is not going to adhere or comply with the medications that we're going to prescribe. Patients, especially females at the childbearing age, thinking to get pregnant or planning for pregnancy or assessing families. Also, we have to look for the evidence for medication efficacy, as well as the doctors themselves, they prescribe it themselves. What about their convenience or the confidence and their experience about prescribing certain types of medications? But how many, how may we define the success differ from the patients and physicians. How would we define the successful treatment for this? Are we in line with these patients, how they look at the medications? So the indicator for successful treatment for the patients is to have pain-free time, quality time with their families, right? And you elaborated on this, Dr. Colleen, and this is how the patients can feel. And from your own personal experience, from our personal experience, this is the time that we look for pain-free time, quality time with our families, so that we can do our works and other responsibilities. For the doctors and for the physicians, the indicators is the numbers. So how many migraine days in a month, and how many acute medications we consume in a month, and these types of the numbers that we look for. So there's some difference in a way between how the doctors and how the patients look at the medications. The American Headache Society guidelines states that a successful preventive treatment must provide a 50% reduction in the frequency of days of headache of migraine, a significant decrease in the attack duration as well as the severity of duration as defined by the patients, the improved response to acute medications, and the reduction in migraine-related disability, and of course, improvement in the functioning and overall, especially important areas of life. So this is how the definition from the American Headache Society. And if we look at this one, so I think we can confidently talk about no evidence of migraine disability as the same way that we talk about the NIDA in multiple sclerosis. We can also talk about no evidence of migraine disability when we look for a successful medications for patients with migraine. So anti-CGRP now available and being used widely for the treatment of migraine, and they are very showing the very efficacious medications with high safety profiles. So they have different formulations. We have the infusable injectable like eftilizumab. We have the injectable sub-Q, different formulations, as well as we have the Gepant, and we have the oral medication that can be used both as acute medications, abortive therapy, as well as preventive therapy. So at CGRP, they have robust evidence based because they are disease specific and they are mechanism targeted. So these are the medications now most of us rely on. And I believe that none of us have any difficulties to convince their patient to start anti-CGRP medications as a treatment for migraine, especially that you have the different options for the route of administration. As for the insurance companies, I believe that we should not face any issues or any problems to convince them to approve the medications for our patients, especially that we have the updated guidelines from the European Headache Federation on the use of anti-CGRP for medication. They stated that in individuals with migraine who require preventive treatment, we suggest monoclonal antibodies targeting the CGRP pathway to be included as first-line treatment option. And the same came from the American Headache Society, where the position statement updated, and that was published quite early this year in April 2024. And the statement says that the CGRP targeting migraine therapies are the first-line option for migraine prevention, and the initiation of these therapies should not require trial and failure of non-specific migraine preventive medications approaches. And this is what was the insurance companies usually ask for. Patients should try other medications before we shift them to anti-CGRPs. So we have also the summary of the expert consensus, which states that the recommendation for the use of anti-CGRP as first-line treatment should be the first-line treatment option. And we can assess the efficacy of these medications after at least or a minimum of 3 consecutive use. Medication can be given for 18 months, up to 18 months, or can be given even for a longer period if required. It also can be given for patients with medication overuse headache. Right. So now I'm going to focus on the Vyepti eftinizumab, which is the main focus for my talk tonight. It's a humanized monoclonal antibodies that bind CGRP ligand. Eftinizumab or Vyepti is the first and the only FDA-approved infusion. We have all the other medications which be approved as a subcutaneous injections, but these are only infusible medications. It's a monoclonal antibodies targeting, as I mentioned, the ligand of CGRP, treating both episodic as well as chronic migraine, and it provides a new mechanism of delivery for already established group of medications of CGRP. So what makes Vyepti unique? Vyepti is considered to be unique because it is designed for robust, sustained, and fast response. And Vyepti is designed for no off-target activity because of high selectivity for the CGRP ligand, and also has a high affinity for the CGRP ligand. Therefore, it strongly binds to the ligand and hence explains the sustained duration of action. It works up to 3 months. Vyepti is designed also for rapid onset of action because after immediately post-infusion, as we will see later in the talk, because it gives 100% bioavailability immediately post-infusion as compared to other CGRP, which works only within 5 to 7 days. So Vyepti has a strong data behind it. It's a preventive effect, both in episodic high-frequency episodic migraine, which with patients with migraine days up to 14 days in a month, as well as in patients with chronic migraine for over 15 days in a month. So it has been evaluated in 2 robust studies. We have the PROMISE 1, which is studies for the high-frequency episodic migraine, and we have PROMISE 2 studies for the chronic migraine. Both were pivotal clinical trials, and these studies evaluated the efficacy as well as the safety of the Vyepti or eftinizumab in the prevention of episodic and chronic migraine, as I mentioned in PROMISE 1 and PROMISE 2. And as you all know, Vyepti was approved in 2020, and that was amid of the pandemic of COVID. So the PROMISE 1, as we mentioned, that is the trial done for assessing the efficacy and safety for Vyepti in high-frequency episodic migraine. This evaluated in the migraine response in over 800 patients with high-frequency attacks. And the study itself was a multi-center, involved 84 centers, that was in the United States and the Republic of Georgia, randomized placebo double-blind control studies. And these patients used to have migraine, monthly migraine days at the baseline of 8.6 days. So you can see this high frequency, of course, of headache days. And the primary efficacy endpoint was the mean change from baseline in the monthly migraine days in the weeks between 1 and week 12. And the secondary efficacy endpoints were they looked at the more than 75 or more migraine respondent rate in the first month, week 1 to 4, 75 or more migraine respondent rate in week 1 to 12, and more than 50% migraine respondent rate in weeks from 1 to week 12, and the percentage of patients with migraine on the day immediately after dosing, and that is day 1. And the other secondary endpoint included the change in acute migraine medications rate in week 1 and 12, and the 100% responder rate also in patients who received the Vyepti. As for PROMISE 2, this is also phase 3 double-blind randomized placebo-controlled trial, and that was performed in around 128 sites, 13 countries, and the study ran up to 24 weeks of treatment. It included over 1,000 patients dealt with chronic migraine with the baseline of monthly migraine headache days of more than 16 days. The primary efficacy endpoint, again, was the mean change from the baseline in the monthly migraine days between week 1 and week 12. Secondary efficacy endpoint, again, they looked at the respondent rate for 75% or more in the first month, and 75 or more responder rate in week 1 to week 12, and more than 50% of migraine responder rate in week 1 to 12. They also looked at the percentage of patients on the migraine on the day after first day, the dosing, and change from the baseline in the migraine prevalence up to week 4. The other secondary efficacy endpoint, again, was the 100% migraine responder rate in weeks 1 to 12. So this is also show how PROMISE was performed. They have the 3 arms. We have the placebo arm. We have one arm who received Vyepti 100 milligram, and we have other arm who received Vyepti high dose 300 milligram. So what these studies told us. So when we look at the 50% or more of migraine responder rate in both episodic and chronic migraine at both doses of the 100 milligram and the 300 milligram, we find that more Vyepti arms were showing more response, like 50%, 56, like 50% in the 100 milligram arm. As you can see, the colors, the Tiffany color and the dark blue color, as you can call it. So it's a 50% and 56% in episodic migraine as compared to 30% in the placebo arm. And if you look at the chronic migraine patients on the left of the screen, then you can find, again, like 60% at both 100 and 300 milligram as compared to 40% in the placebo arm. So that means it significantly that more Vyepti patients achieved the 50% or more reduction in the monthly migraine days as compared to placebo during the first dose period. We're talking about the first infusion up to 3 months. As for the secondary endpoint of the 75% or more response rate, I have almost 30%, and that's almost 1/3 of patients treated with Vyepti experiences 75% or more of migraine days within the first month, as compared to 15% only in the placebo arm. Significantly more Vyepti patients achieved 75% or more in mean migraine days as compared to placebo by month 1 in both episodic as well as in chronic migraine. The primary endpoint that we talked about, the change from baseline in the monthly migraine headache days, as you can see here, the mean change from the baseline in week 1 to week 12 was met, and both Vyepti group, the 100 milligram and 300 milligram, demonstrated a significant reduction from the baseline. Remember, this patient started as you can see, they started as 16.1. That was the baseline monthly migraine days. So that was reduced by almost 50%, by 8 days reduction. So this also shows how effective and consistent efficacy of the episodic and chronic migraine with the treatment with the Vyepti. So also the primary endpoint was met in this study. Patient with chronic migraine and the medication overuse headache as well, they also showed reduced use of acute medication, again by 50% after the first Vyepti dose. And this chart showed that the mean days per month of the total acute medication use in patients with chronic migraine and the medication overuse headache as compared to the baseline of 20 days. So you can see here, this is the baseline. They started all with the 20 in 100%, in the 100 milligram, 20 in the 300 milligram, and that is a placebo. And this is in week 1 and 12. You can see the reduction is almost 50%. Again, that was sustained up to week 24. So also it shows that Vyepti also works to reduce migraine headache for patients who are medication overuse headache. And moreover, this decreases in the acute medication resulted that the patients who are being categorized as medication overuse headache So because of the reduction of their use of medications, they no longer meet the criteria of medication overuse headache as said by the ICD-3. So it can transform also the life of these patients from one category to other. So Vyepti also works very fast, being an infusion. So after the first infusion, it reaches 100% bioavailability immediately following the administration, and it reaches the maximum dose within 30 minutes. This is compared to the sub-Q injection, the same group that gives only 50 to 80% the bioavailability post-injection, and they reach the Tmax in around 5 to 7 days. And this also can explain the rapid effect of Vyepti or eftanizumab. So there was a very interesting observation during the study that that stimulated the sponsoring company to carry out another study. And that observation that although Vyepti is not being approved or not intended for acute or abortive treatment for migraine, statistical analysis showed that almost 50% or more of patients treated with the infusion of eftanizumab were migraine-free the next day post-infusion. So you can see that 52%, and then you have also the 50% reduction of their headache in day one. So the Vyepti reduced the likelihood of migraine from the first day by reducing the pain. So the sponsoring company was stimulated to design another study to see how long does it take for Vyepti to kick in and to try to see if it has any role in treatment of acute attacks within the 2 hours post infusion. So they designed another study. They called it a reliever study, and the patient in reliever study were recruited from the community. So these are the patients who suffers episodic migraine, okay, and they were informed to report when they have an acute attack, given the headache diary, and they were infused during this study. They were infused with the Vyepti while they are having acute attack. They were requested to document the relief in the pain score, as well as the relief in the most bothersome symptoms that is associated with the migraine. So this was the primary endpoint for this study, to assess pain relief within 2 hours, as well as the most bothersome symptoms within 2 hours. And just remember now that the most bothersome symptoms is non-pain symptom that is associated with migraine, and this has emerged now as an important co-primary endpoint in many clinical trials in acute treatment of migraine or treatment medication of migraine, and that was recommended by the FDA. So let us look at the results of the reliever study. Again, Vyepti here demonstrated efficacy within 2 hours when initiated during acute migraine attack, and so it met the statistical significance for both those 2 endpoints, which is the pain relief as well as the most bothersome symptoms relief. So as you can see here in the graph, at 2 hours, so you have seen, just let me put my cursor here. So at this headache pain at 2 hours, you can see this is the placebo group, 12%, where almost 24% of patients achieved pain relief within the 2 hours. And this is the most bothersome symptoms. In 50% of patients, 55% of patients got relief from this most bothersome symptoms as compared to 35% in the placebo group. And if you look at the 4 hour, you see the headache pain freedom at 4 hours, again, 50% of patients as compared to 26%. And the most you can see in the absence of the most bothersome symptoms at 4 hours, almost 65% of patients reported that the symptoms get better after this time. So however, we know that Vyepti now is approved only as preventive drug, but if it is given during the attack, it also starts work right away. So it's really fascinating medications with very promising to be also, I think, to be approved as treatment for acute attacks, acute medication as well. So it's not only the GPAN that can work during acute attacks, but also we have biopsy as another option. So this is just to emphasize the rapid effect of the medicine, and the chart shows that the response per each half an hour, freedom from pain and most bothersome symptoms, starting from the just at the end of the infusion, half an hour, as you can see from the graph. This is sustained for up to 48 hours. So just to emphasize this point again, when administered during a migraine attack, so biopsy or eptinezumab treatment resulted in rapid improvement in headache pain, as well as absence of most bothersome symptoms, and a robust separation from placebo at 1 hour can be observed after 30 minutes only of the administration. So how long the effect of this infusion lasts, we can see it from here. Biopsy starts working from day 1 after the infusion. As you can see here, the baseline in the shaded area, that's the baseline. And then you can see the drop from day 1, and the effect is early and stable and be sustained up to week 4, as shown in the graph, with the same effect. And this allows to assess patients after the first month of the infusion, rather than waiting for 3 months to see whether the patient has improved or is responding to this infusion or not. Actually, this is an indication also, if the patient shows an early response, that's an indication that the medicine is active for that patient, and this can give a relief up to 6 months once the patient gets the medication. So it's a positive effect in the first months of using eptinezumab, and I'm sure that the patient can enjoy having pain-free times for many months afterwards. So what about the patients with chronic migraine? And the baseline, as we mentioned earlier, of 16 days, right? So again, biopsy demonstrated sustained efficacy, demonstrated by 8 days reduction in monthly migraine days or more in both patients who received the 100 milligram as well and those who received the 300 milligram. And the effect was sustained throughout the 24 weeks. Safety and tolerability, and that has also been studied in another study called the PREVAIL study. And in the PREVAIL study, we have, this is 2-year data from PREVAIL study, which was a single-arm open-label study. And PREVAIL evaluated the safety and tolerability of biopsy in patients with chronic migraine who received the highest dose, 300 milligram. So just noted that for the assessment of the safety, they looked at the highest dose, and when they look for the efficacy, they look for the lower dose, right? So what did the study show us? The PREVAIL study, let's talk about how it was performed. This outline of the study, it included 96 weeks of treatment, 48 weeks followed by another 48 weeks treatment, and adults with chronic migraine who received the high dose, as we mentioned, the 300 by the 30 minutes infusion every 12 weeks, and they were given up to 8 doses of the medications, and patients were followed up to 20 weeks after the final infusion until week 104. So this is a summary of the treatment emergent adverse event from the clinical trials, and there were no alarming safety issues, as you can see here. And during the 2 years, the most frequently reported side effects were the nasopharyngitis and the upper respiratory tract infection. We did not have any issues with the blood pressure or the blood pressure issues, as we can see in other forms, and there is no also problem with constipation. Hypersensitivity occurred in around 5 patients, and that was not serious and only during the infusion. So once we finish the infusion and patients safely receive medications, there is no worries that they can get any side effects after leaving the hospital. Looking for the migraine-related disability, which is more of concern for us as physicians as well as for the patients, at week 12 and week 104, approximately 80% of patients reported little or no disability or mild disability at week 12 through week 104 assessment. And the level of disability was here as assessed, of course, by the MIDAS or by MIDAS, means that biopsy provide a meaningful and important improvement in patients with migraine starting from the first dose. More than 80% of patients treated with the biopsy reported clinical meaningful reduction in MIDAS score over 2 years, and this means biopsy increases the potential for patient productivity and engagement in the everyday life. And I believe this is what we meant earlier by that, by achieving that no evidence of migraine disability. We offer these patients successful treatment to control their life. Although that we know that there is no cure for this medication, but still we can control their symptoms very nicely. So just ending my presentations here, the migraine preventive effect of eculizumab is rapid and sustained, and the effect is observed from 1 to 2 hours after the infusion, and this could improve adherence, of course, to treatment, being very simple and very rapid acting medications. And of course, about how it will be administered, we will hear more about this from Ms. Joelle later on. However, it is a 100 milligram infusion given over 30 minutes, and of course, there is no loading dose is required. So to conclude my talk, just to say that the data of biopsy showing that it's eculizumab or biopsy is a potent, fast, effective, and safe preventive treatment across migraine diagnosis, whether it's a chronic or episodic migraines. And biopsy is effective as preventive and also demonstrates immediate efficacy, and it starts to work as early as day 1. It also works during migraine attacks. Its rapid onset of sustained efficacy potentially reduces migraine burden and disabilities related to migraine. And as for the real world data, we will hear about more about from Dr. Sakra on that. Thank you so much for your attention, and I think we'll give the questions at the end.
You are mute, Colleen.
Thank you. Thank you, Dr. Suzanne. We move to our next speaker, Dr. Mustafa Shaqra. Dr. Mustafa is a consultant neurologist at Sheikh Khalifa Medical City, Abu Dhabi. He has particular interest in inflammatory and degenerative diseases of the CNS. He runs the clinic of multiple sclerosis and Parkinson's disease at SKMC, graduated medical school from Damascus. We're not going to say which year, and received his main training in general internal medicine and neurology subspecialty in major university hospitals, carries MD, MSc, MRCP, and FRCP in medicine and neurology, and additionally, he has authored and co-authored many articles in the field of neurology.
Thank you, Colleen. Good, you did not mention the year of graduation. Okay. You see my slide now. Okay. Good evening, my friends, my colleagues. My name is Mustafa Shaqra. I'm a neurologist at Sheikh Khalifa Medical City in Abu Dhabi, and today my task and my lecture is about how to move from theory to real world. I believe majority of my slides are a replication to what already presented by my colleagues. So hopefully we'll go through all of them very fast. So this is my disclosure for this presentation. And starting with this experience here, this is two cases. I'm presenting two cases from my clinic. This is a lady who's 33-year-old lady. She has a history of headache for several years. Recently, she started getting frequent attacks of migraine due to some family issues that impacted her life and reflected in increasing in the number of migraine, not only frequency and severity. As you can see now, migraine, she is having at least 5 migraine attacks, and at least the duration of every attack about 2 or 3 days. So at least she's having 10 days of migraine every month. She said that during the acute attacks, she is her functionality is impacted remarkably, although in between she is doing well still. So she was seen previously, prior to showing up in our clinic by another colleagues, and she was advised to reduce her weight. Although she was not remarkably obese or morbidly obese, she was a little overweight, but again advised to reduce her weight. Also, she started getting amitriptyline due to the stresses in families and during to sleeping disturbances and during to headache. As you know, amitriptyline is a medication that is one of the standard of care therapies that we use for very long times as prevention. She used it, but she did not feel any good effect on the severity and frequency of her migraine. She used ilitriptan, Rilbax as rescue therapy with good effect. Never been advised for CGRB, probably due to frequency and severity of headache. No one did mention this type of therapy for her. So being impacted by her increasing frequency and severity of migraine, she showed up in our clinic. And in fact, she started getting this first infusion. We suggest to start anti-CGRB. We presented all the medications to the lady, and she preferred to take the medicine that is not having a lot of contact with the hospital. She is not from Abu Dhabi per se, so she has to travel some from area that is remarkably remote from the city. So she preferred to take this medicine, and what to our surprise and to her surprise, the effect was remarkably positive. Since the first infusion, the attacks of migraine reduced with the first 3 months from 5 attacks or 6 attacks per month to 2 attacks, and the migraine days is not more than 3 days per month. Second infusion was in April 2024, and subsequently she's doing well. I saw her, I think, in last August or last month, I think last August. And she said that hardly she had used any rescue therapy, and she doesn't recall that she suffered from any migraine attack for the past month. So this is a typical case or classic case of episodic migraine, as mentioned by definitions by Dr. Kalin. So whenever migraine attacks are less than 14 days, it is episodic migraine. Whenever it is less than 8, it's higher than 8 days. It is high frequency episodic. Less is regular episodic migraine. And this is, as you can see, this typical episodic migraine that responded nicely to infusion of optinizumab. So the effect was very fast, shown up in the first month after infusion, and there was maintaining and improvement in frequency and severity. So we know from now what already presented that we have evidence that the effect of the optinizumab on migraine, on pain, is starting even within the 1 hour, as it was shown by Dr. Suzanne. The freedom of headache also give a freedom of headache that has been noted immediately 4 hours, within 4 hours from the infusion. Again, this is probably the reason why some people ask why it's not considered as rescue therapy in acute attacks of migraine. It has the same profile as any rescue therapy of migraine. So we know this. We know also the response is maintained. We have some evidence that shows the maintaining of the effect over weeks after the infusions. And also we have also for a group of people, many small group who did not show early response, although they show a remarkable improvement in response later on. So bioavailability is 100% when you compare it to other competitor. And again, the Tmax, the maximum concentration of the medication inside the blood is in within 30 minutes, which is this is remarkable and superior to other therapies that for competitors which are available as subcutaneous injections, which sometimes take 5 to 7 days, sometimes even 4 to 14 days, in fact, to get the Tmax or Cmax concentration of the medicine. So it has bioavailability, pharmacokinetics that are very attractive and very good. that explain the fast efficacy and the strong effect and prolonged effect even. So the impression of this lady was here reflected in these words, and I am truly excited about my progress with this new migraine therapy. I can leave the house without worrying about migraines, and I feel much more relaxed when making plans. And this is, I think, was touched by the Dr. Colleen and Dr. Suzanne when it comes to interictal and ictal phase whenever related to migraine. Migraineurs always having the fear of getting attacks in between attacks. Therefore, they have very limited plans, and usually they're afraid to make any plans or any participation in any social or familial functions due to fear of getting attacks of migraine. Eptinizumab is powerful and efficacious. Again, this is a slide was presented not just now by Dr. Suzanne. As you can see, when they looked for the pre-specified secondary endpoint of the studies of PROMISE 1 and PROMISE 2, when they looked about 70% improvement in migraine days. And as you can see, it is I think, let me here. As you can see here, this is from first month after the first injection. Again, it is during the first cycle of the dose. There is superiority of patient who received eptinizumab over placebo in targeting 75% reduction in migraine frequencies. Again, it is continuous on the second dose and third dose, and not even it is there is still significant percentage, but this percentage even is improving with time. So same when it comes also for chronic migraine. So this is a powerful point towards using eptinizumab. This is probably the only anti-CGRP monoclonal antibodies that had shown this effect and was looked at as pre-specified in pivotal trials. When it comes to 50% reduction, which is the primary endpoint, again, you find the superiority from the first dose and from the first few weeks, then during the three months, then again with second dose, when regardless if this is a chronic migraine or episodic migraine. My other case is different. Now we are shifting towards the chronic migraine. Again, this is a lady who is having migraine for more than 25 years. And currently she is 58 years old. And she has, when she showed up in our clinic, she is suffering from at least 22 or 25 days of migraine per month. She has a long-term history of treatment. She tried all possible therapies, name them, whatever you want. This anti-epileptic, antihypertensive, antidepressant. She tried melatonin, she tried Botox, she tried calcium blockers, she tried all type of medication, nerve block. Nothing works. In fact, she tried Erinomab in 2019, just prior to the pandemic. Unfortunately, she got hypersensitivity reaction and admitted to ICU. Therefore, after that time, she swore to God not to use this type of therapy at all. So she used lasmeditan as a rescue therapy, sometimes with or without naproxen. Her life is completely terrible. Her life all is about migraine. Nothing out of migraine. She doesn't have any activities. She doesn't go to any functions. She doesn't participate in any familial functions, social functions. She doesn't even have the capacity to drive. Her main issue was driving. And I'm fearing that she is in prison without driving. So she showed up, I think, in last year in our hospital, something like in September, whatever. So I think around September, and explained to her that all medication were tried. In fact, without trying anti-CGRP, she tried one of them, and unfortunately, because of hypersensitivity, she did not want to get any medications of this group. After one visit or second visit, she was convinced to use eptinizumab in infusion. And surprisingly, for her surprise and for our surprise, even there was remarkable reduction, more than 50%, at least not 75, not in fact, almost like 50% reduction in days of migraine with the first infusion. And she was extremely happy for this response. And she prayed to God to keep this response for her life. Was significant, in fact. Since that time, she's taking this medicine for every 3 months. Now, her last infusion was in August 2024. And she said that in every month, she has almost 2 or 3 attacks, 4 attacks of migraine that even doesn't require any active treatment. She has not even used dasmeditan anymore. Hardly she's using only naproxen for treatment. She is a remarkably different type of person. If you get a picture for her before and after, you will not recognize this lady at all. This is different lady completely. So she was extremely happy with this outcome. She is coming to visit strictly on time. She doesn't even miss one day. So this medication have very fast effect. This slide was presented by Dr. Suzanne, and it showed the effectiveness. And this is probably the observation that raised the issue why we don't use eptinezumab as rescue treatment. Why don't we use it as an IV therapy in order to terminate the acute attacks of migraine? As you can see, the group of patients who were having migraine and same day of infusion, regardless of chronic or episodic migraine from PROMISE studies, by the way. So they get at least 50% within 24-hour reduction or in their migraine. 50% of them get migraine-free in next day after infusion. Not this again, this is again presented by Dr. Suzanne. They looked based on that study on again, I think this is a previous study, and they looked at the not only improving or being free from headache and pain, they looked also for most bothersome symptom. As you can see again, there was remarkable freedom when it comes to pain within 2 hours. Freedom means that pain goes from moderate to severe to zero. Again, there is absence of most bothersome symptoms, which are either photophobia, phonophobia, or nausea. As you can see, there is significant percentage of this patient, almost more than 50%, they get exactly absence of these symptoms within 2 hours. Again, the headache freedom, also the percentage is increasing when you consider the 4 hours. Same for the most bothersome symptoms. And not this only, they also notice that there is even reduction in the use of rescue medications. So it acts as rescue treatment and preventative treatment in same time. So whenever you are using preventative therapy, there is associated also reduction in using of rescue therapy. And this is the same is happening on. That even also there is pain freedom, there is absence of most bothersome symptoms, and again, there is also reduction in the use of rescue therapy. When they looked about the freedom of most bothersome symptoms, as you can see again from this slide here, it is in 2 hours, there is remarkable separation between the placebo and the eptinezumab arms. Both arms here are acting almost in parallel till 2 hours. Then it shows the superiority of eptinezumab in getting freedom of all of most bothersome symptoms related to acute migraine attacks. So this lady, in fact, was a success story. She said, I was initially very skeptical. She was very skeptical. She, in fact, she refused the first visit and second month visit to take any of this therapy due to the bad experience with hypersensitivity. But she said, I lost all hope finding a relief from my migraines. However, I am happy to say I finally feel hopeful again, and I can see a brighter future ahead. So again, as I said, she was extremely happy. She was extremely happy also to return to her driving. Now she's driving her car by herself. She comes to the infusion center by herself. She is extremely happy. She doesn't miss, not a day, she doesn't miss an hour on infusion. This said, I think, again, a slide that was presented when they looked about the adverse event. They took chronic migraineurs and they start giving them the highest dose, which is eptinezumab of 300 12 weeks, and they followed them up to 84 weeks. Again, there was the adverse event reported was consistent with what we know from PROMISE to study, and there was no alarming or new findings or a new reported adverse event. Same, I think the same slide was same was presented by Dr. Suzanne, so no need to repeat this. This is again for MIDAS. The meaningful improvement was maintained through the 2 years of following up. There was a remarkable improvement in quality of life. MIDAS is a reflection of functionality and the quality of life of the patient. And as you can see, majority of the patient maintain meaningful clinical improvement over 2 years of prescriptions. This is a medication that is very attractive. It is 100 mg that is infused over 30 minutes without pre-medications, without a loading dose, and hardly to find adverse event among the patients. On our group, we did not encounter any case of hypersensitivity or serious reaction to the infusion. Now I'm going through some data published recently over 2023 and 2024, and this is again a paper that published last year. It looks about this is all real world data. This is from different centers around the world, and this is a 31 patient of obtinizumab treatment. The case resulted in decreasing of monthly headache days almost by 50%, and including migraines days by almost 50%, at least after 6 hours, 6 months of a treatment. So with second infusion, this is real world data when it comes to using obtinizumab. There is decrease in headache days, regardless of the, sometimes a headache is associated with medication overuse headache or non-specific headache, and migraine. So at least by 50% after 6 months. This is again a study from a German center. I think again it was published in 2023. This is multi-centers, multi-sites in Germany. Analysis of 79 patients for chronic migraine, and they experienced significant reduction in headache frequency. Not only in headache frequency after using the obtinizumab, but also again for using of acute or rescue medications for acute treatment. This was remarkably significant after first infusion, after 3 months of treatment. When it comes to patient satisfaction, this is a review study. This is a multi-site again in the US-based study, multi-site. Again, it is an observational study, looked at patient with obtinizumab, and this time they looked about chronic migraine patients. Majority of them, most of the patients noted increasing, this is a quality here, not a quantity, in good days per month from average of 8 to 18 after starting obtinizumab treatment. So the good days of the patients, that mean almost like migraine-free, went from 8 days to 18 after the first infusion of the medication. This is a review study, multinational, recently published in 2024. And it had shown not this one also, they noticed that also there is a reduction in using rescue therapy from 81% of cases to 26% of cases after starting treatment. So all these are real-world data reflecting what we learned from our practice, what we found from the pivotal trial, PROMISE 1 and PROMISE 2, and other study, PROVIL and RELIEF. And again, this is a true reflection to our even practice. So my conclusion, after 2 years of using obtinizumab, this is a very attractive therapy. From patient's point of view also, it is a first for if you go to select the patient, this is with all the patient of migrainer patients, migraineurs with chronic migraine, with episodic migraine. It is an attractive option for any patient, also the patient who want to get very powerful, minimal adverse event, and reliable medication. You know that this medication over, as you can see from real-world data, from pivotal trial, and from personal experience trial, this is one were very strong. In fact, not to tell a secret, we used to tell patients whenever if there is no response to obtinizumab treatment and migraine, then diagnosis is wrong. We have to think about other diagnoses. So it wasn't, we used to start this medication as last resort, but currently we are using it as a first treatment whenever it comes to when we need a powerful therapy against a migraine or who is having or suffering from remarkable severe migraine in frequency or severity. From the infusion, it is very fast infusion, about 30 minutes, doesn't need any requirement, doesn't need any loading dose, doesn't need any pre-medications. It is very favorable, easy, 30 minutes every 3 months. The effect is fast, as we saw previously. It happened from first few hours. Again, there is remarkable, even being for migraine-free first day from the pivotal trials, it is also having a very powerful outcome. Adverse event profile, it is hardly to appreciate any adverse event. We did not encounter any reaction hypersensitivity. Still, it has to be considered. It has to be observed for any hypersensitivity. The most probably common adverse event related to infusion are pruritus and some itching and erythema, especially at the site of infusion. Patient satisfaction, we saw even the review trial and the previous trial that was in Germany. Patient like IVPN, no home injections, no home medicine, even don't have to start any therapy, no reported till this moment any wearing of headaches. You know, for the maps, many of the maps there are reported now. Many articles has published reporting wearing of headaches. We did not encounter this till moment of eptinezumab. So what make eptinezumab, what makes Vyepti different? It has 100 bioavailability. We saw in the first few slides that bioavailability is 100%. The Tmax is within 30 minutes. It is only 4 times per year. It is very attractive. You don't have to come every month to the hospital. You don't have to take medicine every month or every day or every other day. The clinical outcome and data make it also support it is a powerful and reliable medication. By this, I'm ending my talk. I hope I am in the time. Thank you very much for listening. I'm waiting for the questions. Thank you very much.
Thank you, Dr. Shahra. In fact, maybe it would be better to move with the talk with Joël before heading to the panel discussion. So our next talk will be given by Joël Massouh, who is currently the clinical manager of the Neurology Institute and MS Center at Harley Street Medical Center, Abu Dhabi. She's a certified multiple sclerosis nurse, and she is a member of the Multiple Sclerosis Nurse International Certification Board. Joël, the floor is yours.
Thank you, Dr. Kaline, so much for the introduction. I'd like to thank everyone for staying with us till the end. And of course, thank you so much for IVPN for the organization and for Lundbeck for really sponsoring this educational activity and focusing on the care of people living with migraine. Of course, my fellow speakers and faculty today did an amazing job setting the stage for us to understand the importance of migraine as not just a headache, like we described, the burden of migraine as a disease, and the evolving landscape of treatments in migraine, where we are now and what we reached in really stopping migraine in its tracks and allowing people to live a better quality of life, such as we described. So we described all the evidence and the clinical trials. We also talked a lot about the real world evidence, which we really see in practice as clinicians, all of us. And for also nurses and pharmacists and other healthcare professionals, it's very important for us to really talk about how we also deliver the medication to patients, how we complete this cycle. So from science and basic science to the bedside. So this is where we will continue now. And with this, I will share my screen. Okay, I think you can see my screen now. Okay.
Yes.
Thank you. So today, at the end, we're going to focus on the dosing and administration of Vyepti, which is eptinezumab. and just discuss simply how we administer this treatment. These are my disclosures. We're going to have a bit of a visual introduction later on the supplies, but for all of you healthcare professionals, especially nurses and pharmacists who are very involved in providing infusions and have experience in providing infusions, we need regular supplies for this infusion. So there is an ease of administration, and this is what really differentiates Vyepti from other kinds of more complex monoclonal antibodies. We don't need a lot of supplies, just a regular sterile needle and syringe, a small bag of 100 ml NSS or normal saline, an IV infusion set with either a built-in line filter, or we can add a filter if the set does not include one, and an additional 20 ml volume of NSS, which we will be using at the end of the infusion. Now, Vyepti comes in a vial, and of course, as other medications, it will require dilution prior to administration. Of course, as healthcare professionals, we have to use appropriate aseptic technique when preparing this infusion. My colleagues described the difference between giving a 100 milligram dose and a 300 milligram dose. We have patients maintained on either or of the doses. The difference is only simple. It only comes in a 100 milligram vial. So if we are preparing a 100 milligram dose, of course, we have to withdraw 1 ml of Vyepti from a single dose vial using, of course, a sterile needle and a syringe, like we said, and inject this 1 ml into the 100 ml bag of NSS. We should not be using any other diluents at the same time. If we're preparing a 300 milligram dose, we will withdraw 3 single dose vials, so 3 ml, using, of course, again, sterile equipment, and inject these 3 ml into the 100 milliliter bag. Like other medications we prepare, we're not supposed to really be shaking the medication. We're supposed to gently invert the Vyepti solution to mix completely, so we don't shake. And what about stability, some of us might ask. So following dilution, the solution must be infused within a maximum of 8 hours. During this time, it can be stored either at room temperature or in a refrigerator at 2 to 8, but we must be aware that, like all monoclonal antibodies, we cannot freeze, so it should not be put in a freezing temperature, or in the freezer. If we don't use the medication past these hours, we are supposed to discard any unused portion remaining in the vial or in the bag if for any reason we were not able to use it for the patient. Now, as we said, and as my colleagues explained before, there's no monitoring really required during and after the infusion of Vyepti, no significant monitoring. So it does not really generate a burden on nurses or on other healthcare professionals. Why? Because it's generally well tolerated, as they beautifully explained, with less than 2% of patients in general discontinuing treatment due to side effects. And this is what we see in clinical practice as well. Most common side effects will include nasopharyngitis or hypersensitivity reactions, which are generally mild to moderate in severity. And usually the incidence decreases after subsequent doses. Hypersensitivity can occur, but it's usually during or immediately after IV administration. And this is why we don't need prolonged monitoring. It generally resolves without treatment or with routine symptom-based medical management. And this is, of course, clinician-based judgment. And as nurses and healthcare professionals, we are supposed to be in close contact with our providers and physicians and inform them immediately of any occurrence or any new occurrence. Of course, our patients are supposed to be scheduling their appointments for follow-up, and we'll talk about that briefly. Now, we said the infusion administration instructions are very simple. After we prepare the solution itself, we will use the inline filter or any add-on filter, and we will infuse, of course, at room temperature. The duration, as was already mentioned, it's only 30 minutes. So very short infusion. And this is kind of one of the things that really attracts our patients when we talk about ease of administration. So when we're trying to increase the quality of life of our patients, we want to give them therapies and treatments that allow them to live as normal a life as possible. And this is what we do with other neurological diseases as well, other chronic diseases too. We're moving into higher efficacy therapies with less side effects. So we're calling it flipping the pyramid. And this is the same for migraine as well. We're giving higher efficacy therapies with less side effects, with more really ease of administration and better tolerability. And this is the case as well for Vyepti. So after we finish the administration and everything is complete, we flush the line with an additional 20 ml volume of NSS, just to make sure that everything, the medication has been infused fully and the line does not contain any medication anymore. Like other medications we prepare, we are really supposed to be very thorough when we are preparing medications. These are very high, high efficacy medications with high cost, and we don't want to have any risks or breaks in the cycle of preparation and administration. So, of course, the concentrate for solution has to be clear to slightly opalescent. So we need to be observing this before we dilute. Inspect it visually, make sure there are no particulate matters or discoloration prior to administration. If there is, we're not supposed to be using this vial itself, and we're supposed to be checking with our pharmacy. Never administer Vyepti as an IV push or bolus injection. This is made to be given over 30 minutes and never as IV push. And we're not supposed to give any other medications at the same site or through the infusion, same infusion set, or mixed with Vyepti as well. So visually, just to look at what we need from supplies, as we said, the vial itself, which comes as a small 1 ml vial. So every drop is very precious. And this is what I tell to the nurses I train when we're starting any new nurses or onboarding nurses. We have to really be very careful with all medications that have small volume. Every drop really counts. The infusion set, this is an example of an infusion set that contains an inline filter, or we can have add-on filters that are 0.2 to 0.22 microns. So we can add them to our line at the end and attach them to the patient's entry path. Of course, you are all familiar with the other equipment, needles and syringes, the 100 ml bag, and the syringe containing the 20 ml we will use at the end. We discussed all these, but for a visual presentation and for the difference between the 100 milligram dose and the 300 milligram dose, always remember, check your orders and avoid medication errors. So for us, because we are a center where we have a day infusion center and everything is linked to each other. So we know the plan for our patients. We see our patients in clinic and we refer the patient to our infusion center. So everything is really linked and the possibility of errors is very minimal. But if you are giving your patient infusions in the hospital, or just make sure that all the communication is right and the right dose, right patient, all rights and safety is really being ensured. Discharge instructions are very important, and we take this time when we are dealing with our patients to really make sure that they schedule their follow-up appointments. Sometimes we want to see them earlier, especially for patients who are dealing with severe migraine attacks, because the doctors really explained also the difference or the advantage of Vyepti and how it, even though it's a preventive medication, it really has a very fast onset of action, and that's the benefit and advantage. We give it sometimes to patients who are dealing with, of course, besides the fact that they have episodic or chronic migraine, sometimes they are dealing with acute migraine attacks, and we want to abort this attack, and it really works fast, stopping this attack. We see it all the time in clinical practice. It can have an effect very fast, as mentioned, and explained, especially with the 100% bioavailability and this really rapid effect we discussed. So sometimes we schedule our patients for follow-up really quickly because we want to see how good they responded and really plan based on that. Sometimes we decrease their acute and abortive medications based on how well they responded to Vyepti, and thus we avoid medication overuse, as my colleagues explained. If patients are doing fine and stable, they don't have really a lot of acute headaches, we can keep the next appointment until prior to the next infusion, just for follow-up and checking the efficacy of treatment, especially if this is the first time we are administering Vyepti. And then based on efficacy, we will renew, and generally it's most of the time always efficacious, and we will give the patient the next infusion. And just like Dr. Mustafa mentioned, these medications are not just therapeutic, they can be also diagnostic. When people do not respond to a medication such as eptinezumab or Vyepti, we have to question the diagnosis. And this is what we do with other conditions as well. When people do not respond to very high efficacy monoclonal antibodies, it makes us question the diagnosis. So this is how good these medications are in terms of efficacy. So after the infusion is complete, as we said, we will discharge our patients. Always make sure not to give any other medication at the same time. Why? We're afraid of interactions, of not really being sure if the patient develops any hypersensitivity reaction. What was the cause of the hypersensitivity reaction or the allergic reaction? Was it the Vyepti or any other medication? So what are the contraindications? If our patient has any allergy or previous known allergy to eptinezumab or any other ingredients, we are not supposed to infuse. If there is a history of heart disease, the patient, of course, these are cleared before in clinic and discussed with the provider and the physician, neurologist. History should be cleared, and any contraindication should be discussed prior to prescribing, of course. We discussed the possibility of allergic reactions, and these should be reported promptly. But of course, patients will be receiving this under the supervision of their nurse in infusion centers or in the hospitals, as we mentioned. Side effects can range from common symptoms, not very common, I mean 1 in 10, as we said, but classified as common, and these are like the symptoms of stuffy nose and sore throat, which might occur, but really in clinical practice, we do not see them that frequently. And if we do, they are very mild to moderate. It's generally a very well-tolerated infusion, simple to administer, simple for the patient, and doesn't really occupy much of our time in the infusion center, which is also very good because our patients can really leave home quickly, and we can provide multiple infusions as well. In clinical practice and in clinical studies, most of these allergic reactions were really mild to moderate and did not require major medications. Now, just to go over some materials you might encounter as nurses or as patients, and these are educational materials that can be very helpful. We discussed most of them, but we'll discuss some frequently asked questions. So this, we went over all of them, but let's discuss these frequently asked questions. So we talked about the adverse events. Now, what should you do if your patient really had an adverse event during their infusion? So just like we deal with any IRR or infusion-related reaction, of course, we should be only administering these medications in centers or hospitals that are ready to treat any kind of allergy or hypersensitivity reaction. So fully ready with emergency sets and everything. Granted, we might not ever need them, but we have to be fully ready for safety. Infusion can be temporarily interrupted or completely withdrawn. That's based on clinician judgment. And of course, we need to follow our institution protocol in managing adverse events. So what happens in clinical practice? We really monitor our patient. If the patient reports any kind of adverse reaction, such as sore throat or rash or anything, we will immediately stop the infusion and we'll inform the physician to assess the patient and see whether we need to give a period of interruption and rest and re-challenge and give the medication again, or if we need to give any symptomatic treatment, and that can range from steroids or any antihistamines to any other medication deemed essential by the physician. The need for the filter, with other medications as well, this is important to remove any contaminants and avoid phlebitis due to any particulates present in the solution. Tips for you as nurses, what about the gauge needle that is used for the infusion? This is a medication that can be given with a 22 gauge needle or 24, so it doesn't need a large bore needle. Infusion pump, we use your regular infusion pumps that is available in any hospital or center, does not need any special preparation. Definitely make sure not to, this is very important safety-wise, administer as IV push or bolus. We do not need to have a fixed time for monitoring post-infusion, but this should also be based on guidelines of the institution or clinician judgment. So if we feel our patient is not feeling well, we can monitor them for a brief time following infusion, but that is rarely needed. What we do personally for in our setup, for the first infusion, we will probably monitor our patients for 15 to 30 minutes post-infusion. It's not required, as we said, by the label, but we can do it just to have an extra step of safety. Later on, for the subsequent infusions, if patients are feeling fine, we can discontinue this monitoring phase. Okay, and that's technically it. The other points we all discussed before. There are some very helpful as well patient booklets that you can provide to your patients describing migraine and migraine triggers, describing the infusion itself, and what is really the molecule of Vyepti, so patients can understand it in layman terms. And what kind of side effects they can deal with. It's very important always to explain to our patients to come comfortable to their infusion day, wear something comfortable, be able to have something loose around the arms, and bring something to entertain themselves on the day of the infusion. It's available in English and Arabic as well. And with this, I will end. And thank you for listening. And I'll join you as well for the panel discussion. Thank you so much.
Thank you, Joelle. We'll move now to a quick scan of the available questions that were asked. So how do we decide when to give 100 or 300 milligrams Vyepti? Are there any criteria we need to consider?
I can answer that. Yeah, so usually the initial dose is 100 milligram, and then it depends on the patient's response. Then we can increase the dose if it shows like inadequate response or is still suffering severe attack or severe migraine headache. So we can increase the dose to 300 milligram. Sometimes we can use it like a loading dose, and then after the 300 milligram session, then the sessions after he can continue with the 100 milligram only. It depends on the patient's response for the initial dose.
From my side, I usually also have the practice of escalating to 300 milligrams is if the patient did not respond fully, but I never used it as a loading dose. For me, there's no need for loading dose. It's usually the 100 milligram is sufficient by itself, but usually I may try to escalate to 300 if the patient wants better control for their migraines before considering treatment change. Dr. Shara, do you have an input?
Well, I don't have experience in 300, in fact. I did not need to give any of my patients 300.
Yes, in fact, I must say the need is very rare to escalate.
Yes, definitely. And if you go even to study, you will find that the superiority of 300 over 100 is very marginal, in fact.
Very marginal.
I think there is a message that we need to correct here. Can we use Vyepti injection as prophylaxis or only during migraine attack? This was a message given by Dr. Suzanne that it may have an acute effect, but this is not used as an acute treatment. It is a preventive treatment, but it may have an acute effect from the first day after infusion. This is what you meant.
The approval is for preventive only, not for the acute.
Okay. The rate of infusion for Joelle?
Yeah, so it's given over 30 minutes. So it's 100 ml over 30 minutes. So the rate will be 200 ml per hour.
Okay. How do we need to do a sensitivity test before the Vyepti?
No, we don't do that.
Okay. Are there any known issues with joint pain as with Emgality injectable?
Joint pain with
Not
Emgality even?
reported, yeah. Yeah, so in some
Even with
cases are
Emgality,
reported. But for
they are
biopsy, nothing.
yeah, they are speaking about other anti-CGRP monoclonal antibodies, but this side effect was not frequent with the others neither. Okay, any contraindications for this treatment? Kidney or liver dysfunction?
I can answer this question. I think there is no contraindication in renal dysfunction or hepatic dysfunction. This is a medication that is monoclonal injected inside the bloodstream, and it is eliminated by proteolysis. So it is usually no interactions with renal or liver function. Probably the contraindication only if there is pregnancy, of course, or hypersensitivity.
So this is a question to Dr. Suzanne. With the introduction of IV anti-CGRP, how can clinicians ethically justify recommending older treatments with known lower efficacy?
Right. We're still discussing all the options available for the patients. It depends on the patient's factor, the severity of the migraine, the frequency of the migraine, and if there's any contraindication for the monoclonal antibodies, if getting pregnant. So we also look at the patient's history, whether she had a good response to the old medications before, because still we have many patients who respond very well to beta blockers. And still have many patients who are still using amitriptyline, antidepressant, tricyclic antidepressant. So it depends on the patient's factors. It depends on their response in the previous. So of course we give the options, but it's always a decision that should be taken after discussion with the patient, whether they prefer to go for the injections or whether they go for the oral. Like just yesterday, I got a patient with diagnosis migraine, high frequency episodic migraine, but she was very reluctant to start any monoclonal antibodies. And she preferred to start medications first because she said, I don't want injections. Even for the tablets, the monoclonal antibodies tablet, she was not willing for that. So we started her on the beta blocker. So it depends on the patient preference, definitely.
And in fact, also we should reconciliate between best clinical practice and best available practice, because sometimes we are practicing in areas where we don't have access to the newer anti-CGRP medication. So best available practice is ethically always acceptable.
And the cost as well.
Yes.
Cost, yes.
And the insurance coverage issues and all the sort. Why Vyepti should be avoided in patients with cardiovascular and cerebrovascular ischemic events?
I can answer this question. In fact, all monoclonals and G-bands were studied among patients who were excluded, the group who are having active or uncontrolled cardiovascular events were excluded from the studies. So we don't know exactly if they are safe or not. So we know certainly that this type of medications, either monoclonal or G-bands, are safe among patients with stable cardiovascular disease, but not unstable or uncontrolled. So because they did not look at this group. Also, we have some evidence from basic science that who were injected G-bands, in fact, in rats who are having acute strokes, and they found that G-bands worsen the stroke size. So we have some evidence in acute cardiovascular events. It's better to avoid this type of therapies, either monoclonal or G-bands.
And in fact, as in safety matters, And on the theoretical level, there was no vasoconstrictive effect. So
Yes.
theoretically, these drugs are safe, unlike the triptans that are vasoconstrictive and are much more risky for the cardiovascular patients. Dr. Susan, you were...
I just wanted to add that calcitonin G-related peptides is also a strong vasodilators. And when we remove the vasodilation effect and that is protective for the heart, that can cause an issue, especially for
Yes.
patients with coronary heart disease.
Definitely.
Yes,
that
that's
might
what
not-
we were saying, that
Yeah.
unlike what is expected, the monoclonal anti-CGRP did not cause vasoconstrictive effect, even if they inhibited the CGRP. They did not cause the vasoconstrictive effect.
However, this is not a contraindications to be used for patients with hypertension. So not to confuse this with other
controlled
medications.
hypertension.
Yeah.
Okay, anyone of the panelists would like to add something on the subject? Because this is usually where where a physician would be reluctant to prescribe. Dr. Sha'ra, if you want to close the discussion on this subject.
On the subject of cardiovascular,
Cardiovascular.
yeah, exactly what I said. This type of therapies, G-bands or monoclonals, no one look at this group among patients who are having uncontrolled cardiovascular disease, including uncontrolled diabetes mellitus, by the way. So it's not uncontrolled like angina or uncontrolled cerebral disease. No, not uncontrolled cardiovascular disease at all. So it is better to avoid them till we get enough data reassuring us, because we have at least published data among animals models that G-bands worsening a pre-existing cardiovascular events, including acute myocardial infarction and acute strokes. So it's better to avoid these therapies now if the patient is suffering from unstable angina or uncontrolled hypertension or uncontrolled diabetes mellitus. This is my practice.
But for patients who have cardiovascular risk factors that are controlled and on treatment.
It's easy to give. We give even triptans, yani, Colleen. We give Zomig sometimes. We give rizatriptan for patients who are having hypertension, controlled cardiovascular disease. So we give this medication. Of course, if we go to take any rescue therapy, in this case, the better I think is lermigran is the best in this type of diseases if patients are having cardiovascular diseases as rescue therapy.
That's it. I think we are out of time. It was a very enriching session with all of our panelists, and thank you for our attendees for staying with us throughout the session. Thank you, Lundbeck, and thank you, IVPN. And sorry if we missed to swap more questions, but this is for the sake of time. So thank you all, and I wish you a great evening.
Thank you very much.
Night.
Thank you, everyone.
Thank you.
Thank you. Good night.
Bye-bye.
Bye.
Thank you, everyone. Thank you.